Good day, ladies and gentlemen, who have joined us on this Dr. Fundi channel via multiple social media platforms, via Facebook, via YouTube, via Twitter, via Instagram, and also via the Dr. Fundi website. My name is Dr. Fundi Lenyati, and I am the host on this channel. This is a channel that largely focuses on matters health. We focus on health advocacy issues, health promotion issues, current affairs in the healthcare space, but also to celebrate people who are doing great things within the space of healthcare and also beyond the space of healthcare. Now, today, we have a special guest. Our special guest is Advocate Kholeka, who is the Deputy Public Protector. She's been in the job for just close to a year now. On Monday, the 21st, Public Protector South Africa, they actually released a number of reports, but there's one particular report that is of interest to us as a digital health channel, which is the report on the state of the health services or hospitals in the country. The PPSA, they decided to sample 5 out of 9 provinces and look at the issues relating to service delivery, infrastructure, and other things. I won't waste time and try and talk about those. Advocate Gcaleka is the right person to actually, take us through that. Welcome to our channel, Advocate Gcaleka.
Good afternoon, Dr. Fundi Lenyati, and good afternoon to your viewers. Thank you for having me on your platform.
Thank you, thank you. I was trying to prepare for this interview, and I looked at the volume of the report that you guys came with. It's called the Factual Report on the state of hospitals in South Africa. Now, just tell us, what is this Factual Report about? What is it? What led PPSA to actually decide that they need to do some blitz audit of hospitals?
Dr. Nyati, as the country is well aware, when the pandemic hit off in South Africa, the state of our hospitals became under a lot of scrutiny. There were a lot of media reports. There was a lot of outcry by unions from hospital staff on the state of readiness of hospitals, yes, especially during the pandemic, notwithstanding its state of affairs under ordinary circumstances, which they had reported was also not in a good state, but this has actually become worse because of the pandemic. They had to be ready to receive much increased numbers. Working tools were insufficient under the ordinary course. Now they became much under pressure. And some of complaints that had come to us as Public Protector South Africa, we then decided that in the interest of the public and also of social justice, it was crucial for us to then conduct an inspection. So our mandate does allow us to conduct such inspections under our own initiatives of investigations. So that has really been why we embarked on the visits that we had embarked on and chosen the provinces that we had chosen, because those were the provinces where the most outcry was.
Yes. Now, let's just go back just in, understanding the mandate, the constitutional mandate of the Public Protector South Africa, because I think for us, as the members of the public, we need to have a better understanding of where do you guys fit in? What is your mandate so that we can then be able to understand the work that you've just done in the context of that mandate.
Section 182 of the Constitution of the Republic of South Africa sets out the mandate of the Office of the Public Protector as per its establishment in terms of Section 181. Now, what this section says, 182, it also refers to legislation which would then be created, which is the Public Protector Act. So I'll speak to both the constitutional mandate and the mandate in terms of the Act. The Constitution gives us the mandate to investigate, the mandate to report on our investigations, and to make appropriate remedial findings. The Constitution gives the powers to the Public Protector South Africa to ensure accountability of any running of state affairs, transparency in that running of state affairs. Now, Public Protector South Africa is an institution that is established to strengthen democracy, to ensure that there is participatory democracy, to ensure that the state is accountable to the people of the Republic of South Africa. The further mandate that you have, even in terms of the Public Protector South Africa Act, is to investigate any maladministration in state affairs, any misconduct, failure to act, or any action which is prejudicial to the public, and any other malfeasance within the state affairs.
Yes. All right. So you've given us a picture then in terms of your mandate constitutionally and also, the Public Protector Act. Now, again, preparing for this interview, one saw that you guys have got a Vision 2023. And I want you to just tell us briefly about that vision and how it links to this interview. There's about 8 pillars that you guys have of your, mandate. Some are much more relevant to today, discussion, and others are not so relevant. For example, the issue of access, the issue of engaging communities in vernacular, the issue of the footprint, and being the stronghold for the poor. So I just want you to just sample a few of those, not all 8, just those that are relevant to the work that you guys had to do on behalf of the people of South Africa.
Thank you, Dr. Nyathi. Indeed, our 8 pillars of our vision, you've already mentioned about 3 of them. Further is to ensure that we increase our footprint. By increasing our footprint is that there are areas where, for example, there are no offices of Public Protector South Africa, or the offices are far, mostly in the most remote rural areas. Now, when embarking in these inspections, we went directly to these areas. We went directly to these hospitals, and some of them were in rural areas where the communities there cannot easily access Public Protector South Africa in order to lay their complaints on the state of affairs at these hospitals. Also, to leverage on stakeholder relations to advance the interest through MOUs. Now, we have entered into MOUs with various state institutions, mostly with speakers of legislatures in most of the province, because the speakers are responsible for public participation. So where there is public outcry, the speakers will always have that information. So through our MOUs, we are able to collaborate with the speakers to be able to access what are the challenges within the communities, but also that especially when we embark in work like this, we can then easily access government, in respect of the work that we are doing to easily collaborate. For example, in this instance, when we concluded our hospital visits, our site inspections, we actually had a meeting with the Minister of Health where we tabled to him the critical issues that we had picked up. In fact, all the issues that are in this report, we had tabled them to the Minister of Health. So that is part of leveraging on our stakeholder relationships to enhance our mandate. Projecting an image of stronghold for the poor, which you had mentioned. For example, when we went to hospitals like Gcaleka, hospitals in Limpopo, hospitals in Pumalanga, even the hospital in Untitled, those are hospitals which are mostly accessed by poor people, you know. So by embarking in these visits really is to ensure that we're able to service the poor and able to have a stronghold in advancing the interest of poor people in respect of issues of service delivery, you know.
All right.
Ensuring that people are well versed in their rights. I think for public participation, particularly with what we had embarked on the hospital visits, people now know in which state they should be serviced. And as we were embarking on these visits, we were also speaking to members of the public who were going to hospitals for healthcare. For example, in Baragwanath Hospital, some members of the public were even able to tell us that they have been sitting in the queue for a very long time. There's challenge of signage. They are not being directed properly to where they're supposed to go. There was also an incident where a mother was standing outside waiting for a meeting with one of the hospital officials because her 2 babies had passed on and no report was provided to her. So we were instantly able to assist those members of the communities through our site inspection. Persuading organs of state to have effective in-house complaints resolution means we are encouraging government to have their own complaints units so that they are able to resolve their challenges even before they are escalated to us. As such, we also met with the health ombuds, we met with the health standards, so that we ensure that these units are effective and they become effective even in instances like these, and they are able to take leadership in issues which affect the institutions that they have oversight over.
All right. So, right. So there are 9 provinces in South Africa. All right. How did you decide that we will go to these 5? You know, and these other 4, there's no urgency. Maybe even before then. So what was the main purpose of, you know, the visits or the audit that you guys did?
As you are aware, Eastern Cape actually became the epicenter of the pandemic. There were a lot of reports around the Eastern Cape, the failures that members of the communities were experiencing, but that members of staff were experiencing, which were disabling them from being able to deliver efficient and effective services to the people. As a result, there was a number of people who were dying and so forth. So we captured what were the most issues, most areas that were reported on. And obviously it was the Eastern Cape, it was Gauteng. But also what we looked at to strike a balance is that you've got those areas whose people, for instance, are not as liberated to make noise. And those are your rural areas. So hence we went to areas like Limpopo, we went to Pumalanga. And we went to hospitals at the area of Eshowe in KwaZulu-Natal, we went to Gcaleka. So the other areas that we did not go to, it is not because there were no deficiencies in respect of those areas, but we had to prioritize with the limited resources that we had, but also we wanted to speedily engage government so that we can find solutions and speedily have a report that's going to all provinces was going to further delay. But what we have found is really not what we can say does not exist in other provinces. It is really the state of the healthcare in our country.
Yes. So maybe let's get in there. Just before we zoom into specific provinces, if you just had to, look at the work that we have done, what are the recurring themes that you are picking up or that you guys have picked up, that one can almost say these are the broad issues that need attention, in most provinces, if not all the provinces?
Doc, firstly, the importance of consultation. Powers within the healthcare system are centralized to the province, the MECs. Now, when decisions are being taken, there's insufficient consultation. So therefore, most of what is then being implemented is not as per need of the areas. Blanket approach doesn't work. Each hospital has its unique challenges. Therefore, consultation is of paramount importance to ensure that the solution is relevant, is what can assist the staff and what is applicable to that particular hospital. So that's the universal issue that we found.
Yeah.
Secondly, issues of procurement. Everything is centralized to the province. Therefore, the process of procurement becomes very slow. But also there's a challenge in respect of budgeting, because what becomes the priority of the hospital is not necessarily what the hospital receives. The hospital would tell you that they are within budget, they have budget for this particular equipment or for these particular vacancies, but they are not being filled by the province.
Yeah.
Hospital CEOs in tertiary institutions are at DDG level, at the institutions are at chief director level. These are highly senior public servants, but the budget that's being allocated to them and the powers that are being given to them are very limited. So they are unable to
500,000, you know.
500,000 for tertiary hospitals, and then for your district hospitals, it's about 300,000. So they're unable to effectively run the hospital. So you employ CEOs, but you then don't trust them to run the hospitals. So it does require that the issue of the structure, policy and implementation of hospital and the running of the hospitals does need to be looked at, and the issues of the system to really try and resolve the current challenges that are there, because some of them can actually be resolved if only the people that are entrusted with the positions and the authority can be given the full authority. Because if you don't give a person budget, then how do you expect them to run the hospital and have full authority and responsibility over what they have? The issue of the PPEs were centralized. They were specific according to the need, the size, the specifications, because again, there was no consultation. Secondly, they were all centralized to the provincial office, whereas hospitals could have been given a budget to procure their own PPEs. They are led by CEOs after all. There's hospital senior management and so forth, who know the specifications of what is required. And possibly we could have had less of the corruption that we've seen unfolding within the PPEs, by the way. But also the issues of vacancies, which I just briefly touched on previously. High rate of vacancies because of the bureaucracy. Vacancies have to be filled at provincial level. I had a shock of my life in Limpopo, where even a cleaner must be approved at provincial level. Cleaner must be appointed from a provincial level. The hospital didn't have a cleaner for months because the province was not moving. So those are the key issues, but also there are moratoriums that are being put in place by provinces. Again, no proper consultations, because you find that after 3 or 6 months, those moratoriums have dire consequences on the running of the hospitals. In case and the moratorium was that at some point, no nursing staff must be employed. You get to COVID, high shortage of nursing staff. COVID comes, they are told no support staff must be employed. Now you find that the professional staff, medical staff, must now do clerical services and porting services, because no post of support staff must be filled. And by the way, those vacancies would have been there for long because of the bureaucracies that happened. And now all of a sudden they are told, do not fill those vacancies. You know, so those critical issues, but most of all, the interdependent relationship between health and infrastructure in provinces, because infrastructure is responsible for the maintenance of the hospitals. And there's a huge gap there. And hence you find that there's dilapidated buildings in hospitals. There's no maintenance, there's no water, there's no electricity in some of these hospitals. So those were really the common issues across
in the area of, we've had unions, up in arms. At some point, they even took the national minister to court about the issue of the health and safety of their members. Now, in your, blitz, did you guys get to interact with healthcare workers to actually understand on the ground, issues relating to their health and safety, or even the unions for that matter? Yeah.
Yes, we did. We engaged with unions. We always say as public protector, you always get the one side's truth, the other side's truth, and we need to establish what the real truth is. So in order to have that, you need to get both sides of the stories, and unions play a pivotal role in respect of that. And hence that over above speaking to both the management and the unions, we also embarked on inspections of critical areas in the hospitals to see for ourselves. So having had conversations with both management and unions, and by the way, in most of the hospitals, management themselves came out to say that our lives are in danger, the lives of our staff is in danger. We are endangering the public because of poor quality of PPEs that we are receiving, because of the shortage of PPEs that we are receiving. And we were able to see that for ourselves when we embarked on our inspections throughout casualty, trauma areas, and in some of the wards, we realized that there was indeed a challenge.
Yeah. When you were doing your visits, I remember when you guys went to Charlotte Maxeke, it was reported by the media that at some point, some of the senior, people, cried, heads of departments, because they were telling you about the inferior quality of the PPEs that were procured, that were expected, to be used by the healthcare workers who were, in the COVID wards and ICUs and stuff like that?
Indeed. It was a very sad turn of events at Charlotte Maxeke. Senior managers came out to say, they are there because of the passion that they have to serve the people. But if it wasn't for that passion that they had to serve the people, they would actually be asking their staff not to go to work, because it became the biggest exposure that staff had of COVID. And as a result, they also exposed patients because of the poor quality of the PPEs. And at some stages, I said they would not have the PPEs, but also even in the challenge of the waste collections, it really became a bit of a disastrous situation. But it also affected staff and management so much, when that head of the clinical unit actually cried in the meeting and said, we serve, but we don't know if anybody cares that we serve. We do not know that those who are supposed to have oversight over us actually care. And they said the reason why Charlotte Maxeke was able to stand from beginning of the pandemic up until the time that the peak ended, it is because of the dedication of staff, and it's because they had given up on their own lives to save the lives of the people.
Yes. Now, again, there's a recurring theme in some of the reports around the logistics of the PPEs, where you mentioned the issue of central procurement to warehouses and challenges between warehousing and the actual hospitals. What were the things that you guys picked up around that?
What was reported to us is that the PPEs would be delivered at a central area for the entire province. So all the hospitals, no matter where they are demarcated, they had to go out of their own means to get the PPEs. And when you get there, there is no specification that this is for Charlotte Maxeke, this is for Baragwanath. You are just being given. It's one size fits all, you know, no matter what your order would have been, you would not necessarily receive what you would have ordered. But even then, with the strenuous resources that they have, they had to get their own transport to go and fetch these PPEs. They were not delivered to them specifically. So that became a huge challenge for them.
Yeah. I'm zooming in on this issue of obviously being a healthcare worker myself. You know, I understand, you know, the issue of exposure, you know, of healthcare workers. So I'm spending a little bit of time before we get to the specific provincial issues. Now, you know, in terms of the Occupational Health and Safety Act, you know, CEOs obviously have the ultimate accountability in terms of, you know, their workplaces. They can, you know, delegate those, responsibilities to responsible people. However, the buck stops with them. Now, there's another recurring theme about either non-existent SHE committees or risk committees or dormant risk committees, you know, or others are swamped. You know, there's supposed to be so many, SHE committee members per so many employees. So basically the ratios were not in line with what the law expects. So what did you guys pick up around that?
Indeed, we picked up that in most hospitals, they didn't have, for example, specific to COVID, they were supposed to have this risk assessment committees that would from time to time do assessments, especially where there's staff infections, be able to give a report and say that this might have caused this particular outbreak within the hospital and how to mitigate. But also the occupational health committees that are supposed to be there, standard, some of them were non-functional. We couldn't get reports because we wanted reports. We wanted to establish, for instance, what would have been the cause of infection among staff. And that is what those particular committees would have done. And also to mitigate factors even prior, what are the mitigating factors that they would have put in place? What would have been reported to management? What was management able to do? What were they not able to do? We couldn't find those. So there was really non-compliance to the law generally, but it became even worse during the time of COVID because those aspects were much required in order to ensure the safety of the health workers.
And in your visits, did you get any sense that people in those safety committees being frustrated by management, they then went to engage Department of Labor as is expected, you know, if you're not getting, you know, positive outcomes from engaging with your management, or people have not taken that type of, you know, step to say, Department of Labor, come inspect, you know, and possibly, you know, close hospitals where there's serious non-compliance.
No, they had not. Actually, where there was a committee was Baragwanath. They showed that there was cooperation amongst themselves as management.
Yes.
And in other areas, it was very scathy whether there are committees or not. And in other areas, it was clear that there were no committees. But also, you know, the challenge that we had observed and that was communicated by unions was the suppression by some of the management, you know, for unions not to speak out. Hence, some of them decided to go out to the media and so forth, you know, victimization of some of the union members because they were speaking out on the conditions of these hospitals. But none of them had reported that they had actually approached the Department of Labor.
All right. The last thing before we get to the provincial stuff now, there is also the issue of new wards that were created or new hospitals, or what they call field hospitals that were created. But again, you pick up that there was no needs analysis that was done to actually say, okay, we will, you know, create so many additional wards, or we will have a field hospital in this place because of this, and now I'm saying this because obviously the amount of monies that had to be spent to, those lucky places where there was refurbishment was, I pick up that with Bara, there was a lot of refurbishments that were done, and obviously they cost a lot of money, but there are also field hospitals that some of the provinces, set up, which one is worrying now that we're in the second wave, whether those field hospitals are still there or they were dismantled, and all of that. So what did you guys pick up around the decision-making that influences, what kind of infrastructure, expenditure is actually incurred?
Well, it boils down again to the issue of consultation. At Dr. George Mokari Hospital, they were very clear that they were not consulted. A field hospital was put up on the other side of the hospital. It's an open area, but within the premises. And they said, one, that is not their need. Their need is an ICU, and that is what they had requested instead of them putting up the field hospital. Therefore, their dire need was not fulfilled. They needed some other machines. Those were not fulfilled. Instead, that field hospital was put up. And they said, that is not what we need. Look how far it is from the hospital building. How do we get there? Instead of them refurbishing the current hospital building and assisting with an ICU and equipment that is required, they have put up that field hospital, which is much costly, and that for them has no futuristic impact. What are they going to do with that field hospital after COVID is gone? But even now during COVID, they had no use for it. Baragwanath Hospital, they said it was going to assist them, but the challenge was that in the future, what would then be its use? They didn't know what was going to be its use. They had hoped that Lillian Ngoyi Hospital would then be a clinic would then be moved there. They had hoped that that is the plan that the province would put in place, but at that stage, there was no plan.
All right. And about psych or psychiatry patients, you keep on mentioning in your report something about psychiatry patients, especially those who got COVID infections and where they were held and all of that. What's the recurring theme around that?
The recurring theme is that there's no facility for psychiatric patients. There's also no specialized nursing staff, no specialized doctors at these hospitals for psychiatry patients, and there's just no space for them. For example, at Charlotte Maxeke, they have now a few wards that have been put up, but they are not enough. And the worst thing is that they are not staffed. So they then become useless, because if you don't have appropriate staff to man those wards, what then do you do with these patients? Some of those patients, we found them lying at casualty. We found one of the desks at casualty was broken, and they said that there was an attack of staff and patients around by the psychiatry patients that are actually lying there. What was sad in KwaZulu-Natal is that in one of the hospitals, we found that they had built like a cage within the ward. Firstly, their wards are combined wards, male, females, because they don't have space. But within this ward, there's this cage where the psychiatry patients are being kept only when they show signs of being violent. So when they're not violent, they are kept in the ordinary ward, which is a great danger, because how do you know when do they start being violent? And what if they start being violent when there's no supervision? And they say they've had incidences of attack. Now you find this patient laying there in this cage, chained, with no specialized medical attention, because nobody in the hospital knows how to attend to these patients, because those doctors are not trained. Yes, according to regulations, they're supposed to only keep them for 2 hours and then transfer them to the psychiatric hospital. But it is on condition that there is a bed for this patient at the psychiatric hospital. instances, they keep them up until 3 months because there would be no bed in the psychiatric hospital. So and that's common. Even when we went to Ridgeway Hospital, we did find some psychiatric patients at casualty. And there was no separation, no specific attention, because doctors are generalized that they can't specifically deal with these patients. So it is that state of affairs where really in the country, psychiatry has not been zoomed into, you know. I mean, some of what Life as Dimeni would have looked at is really not only applicable to Gauteng, it is what is applicable to the rest of the country. And we had also discussed that with the Minister of Health, that health really needs to move with speed, because with COVID, you actually find that mental health is becoming a major challenge because of the change of environment circumstances. A lot of people are losing families and so forth. Now, there's going to be a lot of pressure in psychiatry, and the country is not ready.
Yeah. All right. Let's now just zoom into the provinces. I know we did 5. I mean, you guys did 5 provinces, but we won't deal with all of them. But obviously, coming from the Eastern Cape and the one that has been in the media then, and it's still in the media now, you guys started around the Nelson Mandela Bay, Uitenhage, and Port Elizabeth. What were the key issues that you picked up there? I mean, and that part is the more advantaged part of the Eastern Cape. You know, the most industrialized part of the Eastern Cape, which is the Nelson Mandela Bay. So, what did you find there?
Firstly, what we found there is that there was a strained relationship between management and labor. Therefore, they were unable to resolve some of the challenges that they were experiencing. There were shortages of clinical staff, there were shortages of support staff, major shortage of PPE and space. You find that non-COVID and COVID patients, there was no space to properly separate those patients, and there was a high risk of exposure to the non-COVID patients. But there was a major lack of equipment, and the basic equipment would be your oxygen tanks, particularly to attend to patients of COVID or suspected to have COVID, but also that the test results took time to get back. But the state of affairs in their casualty areas was really not in a good state. As we say that there was a huge outcry about the kitchen that we found that had been built for 2010, had high-level machinery, which was never put in use, and inadequate food services because of no space even to do kitchenery in respect of the patients, no linen. Most of the patients laid on beds without linen. And the challenge there is that once the patient bleeds and so forth, all the nurses had to clean the mattresses, and it really became quite cumbersome. So those were the major issues there in the Eastern Cape.
That is and the Nelson Mandela Bay,
the Nelson Mandela Bay part of it. Yeah, space was a major issue, but also because of the strained relations between labor and management. Management mostly didn't take some of the advices that labor came up with. And when we listened to labor, we actually found that they had quite a formidable input to make, especially during this time of COVID.
Yeah. Now, moving to the other side, the least developed part of the Eastern Cape, you mentioned a hospital that is called Sulenkama, just outside Umbu. It's also called Nesinite Hospital. And then there's also Mthatha Regional Hospital. Now, reading your report, one can say of the 17 hospitals that you guys went to, it sounds like this Nesinite Hospital or Sulenkama Hospital is the worst of the hospitals that you guys visited. Mud, wards, and many other funny things. Yeah, can you just tell us what you guys found there in Sulengama?
Well, as you can see in our report, we've even pictured how Sulengama looks like. Building totally dilapidated. It was an old missionary building that was never maintained. The wards were falling down, casualty was falling down. I mean, everything was dilapidated in that particular hospital. Obviously lack of space because they had to squeeze everything into the little space, which was still workable. Male and female patients had to use one lavatories because there is no other, you know. But of sadness as well was that for a long time, the hospital staff were living in a dilapidated buildings. They had just built them a new area, which they were excited about. But of most importance was the fact that the hospital itself, you know, was really at a very terrible state. And construction had been happening at the hospital for many, many years without any success.
Because of the lack of payment of service providers. That's what you guys say in your report, that in a number of times work would be commenced and then it would stop because the people say they have not been paid, you know. Yes. And as a result, it's more a hospital that is like a building, you know, what do you call it now, a building site, you know. And I mean, you guys, the pictures you shared there about this hospital that was built in 1929, and the only structure that was actually a solid structure within that, you know, the rest of the building was just mud, you know, mud brick type of structures. So, do you think if Department of Labor would go there, would they approve of that hospital to actually continue to exist in the context of, you know, the health and the safety of both patients and the people who work there?
You know, it's really a place that I can't even call a hospital. So I don't think they would approve of it. But the challenge is then that neighboring hospitals are very far from there. Even now, they still had to transport some of the patients to those hospitals and even have their linen washed about 110 kilometers away from them because they don't have those facilities, which was quite strenuous for them. And we really found a passionate team at Sulengama that despite their conditions, they said the only reason why they were still standing, they were still functioning despite their working conditions was really for the people of that area because they had nowhere else to go. They would not be able to afford transport to the neighboring hospitals, which were much further from that particular area.
And you guys mentioned something about no piped oxygen, you know, supplies. There's no ICU, no high case, you know, they are relying on cylinders that are, you know, rarely replaced, you know. Yeah. Right. Now, Umtata Regional Hospital, that serves, this is about 1.3 million people in that part of the former Transkei. Any highlights from there? That's the hospital where I did my internship in 1990. So I'm quite interested to see what has changed from that time when I was an intern there under the Homeland government that was led by General Bantu Olomise. I mean, I only served 1 year there because of the poor, you know, infrastructure. You know, a great experience that I got there in terms of the work, but in terms of fulfilling, you know, one's, you know, ambitions, it really didn't look like the place. So what did you guys pick up there in Umtata?
What we picked up in Umtata is that, firstly, there was no stable management. Now, once there's no stable management in any other sphere or institution or department or company, there becomes instability in decision making. It also causes instability in service delivery. CEO was acting, there was acting before that, everybody else was just acting there, you know. So that was the major challenge. Secondly, Mthatha Regional Hospital was neglected because of the tertiary hospital, which is just next to them. So they reported that most of the resources would be channeled to the tertiary hospital, forgetting that they were serving actually as both a district and a regional hospital. Now, it comes back to issues of policy implementation. Policy is being created, but no implementation thereof. Now, if you decide that Mthatha General is going to become a regional hospital, there needs to be a district feed that is then being created and very clear terms of reference in respect of the functioning of the regional hospital. Now, that was never done. They still live under that confusion, and their budget had remained the budget of a district hospital, yet they are supposed to do both functions of a district and a regional hospital.
Yeah.
Challenges of space, maternity ward, which was also not in a very good condition as it's supposed to be. They had really tried, you know, to put measures in place, but the issue of space was the major challenge at Mthatha. But also, you know, with a pandemic like COVID, it is important that hospitals do awarenesses and education, and if certain things need to be transported and so forth, they had no motor vehicles, none whatsoever, because of debts that not only they had, they said any other hospital in the area that had a debt, the sheriff went to Mthatha General to collect, you know, so they had no motor vehicles at the time. So it was a real sad state of affairs. PPEs were also a major challenge at Mthatha General.
Yeah. Well, a week before you guys went there, you know, I had been to the same hospital because, you know, I had got wind that there were challenges at casualty there, you know, basic things like oximeters, blood glucose machines, BP machines, hemoglobinometers, you know, basic stuff, you know, wasn't there. But I found, you know, energetic people there who, despite the challenges, you know, we're still, you know, looking to see how to make the best with the little that they have. I mean, there was a young doctor there, Dr. Tony, whom I thought, you know, is a breath of fresh air, you know, very, very energetic. Did you guys, I think he's the same guy that took you guys around.
Yes, indeed. We did. He was actually, I think, acting as well in clinical services. So he took us around and gave us a lot of information on what the state of affairs was in clinical services. Also a shortage of staff, you know, because of the bureaucratic processes, it took time for vacancies to be filled.
Yeah. Let's move to KZN. You know, a big province, vast province. You know, you guys went to Rifley, you went to many places. You know, can you just give us an overview? What's your sense of healthcare services in KZN? You know, again, it's a vast province like the Eastern Cape, with parts that were homelands and parts that were part of the new, you know, NPA. So what's your sense? And I'm asking you in relation to Eastern Cape. You know, if one had to, you know, decide to say, okay, I'm scoring these two. You know, there's Eastern Cape this side, there's KZN the other side. What's the sense that you guys picked up, you know, from the assessments that, you know, from the Blitz assessments that you did?
Okay. I can't say KZN is in a good state, but it is in a better state than the other areas of the country that we had gone to, you know. But they too have major challenges. As I indicated when we started off, the issue of the moratoriums that they issue at that stage, it had just been the one a few years back of the nursing staff, which had caused a major gap, especially during the time of COVID, but also the one of support staff during the COVID times, which had caused major challenges because laundries in most of these hospitals were unable to function effectively. Maintenance was unable to function effectively as a result of that. But also KZN has got a major space issue, infrastructure. The hospitals at Eshowe, their infrastructure is quite old, you know, and one of the hospitals, wow, even where staff lives, one of the staff actually reported that the roof fell on top of him the previous night, you know. So the building is totally dilapidated, totally dilapidated. There is space where the actual office, hospital rather, is, which also has limited space. Shortage of equipment as well. There also a high vacancy rate in KZN. And at the Eshowe hospitals, even the clinics that feed into the hospitals were not there. The only hospital that had it was Christ the King Hospital. But Christ the King there's just no space at all at Christ the King because the community around that area has grown so much. I mean, at the times I had happened to be at the convent school, which was next to Christ the King, Little Flower. So at the time, Christ the King mainly used to service the Little Flower community and a little community next to that. But now it services, there's a huge community that has developed around that area, and it is becoming very, very difficult for them to be able to effectively provide services to that community because of lack of space, but also the issue of vacancies. There was, some acting positions as well there and other positions that were not being filled, but majorly because of the moratoriums that the provinces had taken.
And the unions there, were they happy about their dealings with, the powers that be?
Yes, there was quite a relationship between the union and management there. And there was actually consensus on what the challenges are between management and the union.
Yeah. Now, let's just do a quick blitz on Pumalanga and Limpopo. Let's start with Limpopo. What were the key things that you picked up in Limpopo? Because I want us after this to then look at, you have seen all of this, you released a report on Monday, what next? You know, because a lot of people say, these audits, they are regularly done, we get to hear about them, but we don't hear about how were they resolved? Will they ever be resolved, or it's just a PR exercise? So I want us to get there, but quickly, Limpopo and Pumalanga, what were the things that you guys picked up so that we can get back to, as the PPSA office, how are you going to make sure that the people in those provinces, they actually get what the Constitution, guarantees them at, in Section 27, right to quality healthcare for all people of this country?
Okay, I'll just combine the issues of Limpopo and Pumalanga, really. Common issues there. Limpopo particularly, there was a major challenge in respect of the relationship between union and management. As a result, when we got there, a number of members of the union had been suspended because of raising their dissatisfaction, firstly on how the hospital was being run, but also, in respect of the issues of COVID, because they had indicated that they were highly exposed, which was the truth when we had done our site visit of the hospital. The hospital was poorly maintained, the hospital was poorly run. When we got there, in fact, the CEO was not there. There was an acting CEO. The CEO, I think, had reported sick or something. So there was an acting CEO who really did not know what were the issues, but it was the head of clinical services. So you found that they were also not transparent with us in respect of what their challenges were, which is quite a concern because we expect management to be transparent. We are not there to chastise management or anything. It is a fact-finding mission to ensure that how do we assist government to strengthen its services, to be able to provide the services that are expected according to the Constitution to the people of South Africa. So that was the major challenge that we were confronted with in Limpopo. And
issues around PPEs, were there any issues there?
There were major challenges around PPEs because that is exactly what had caused the bad relationship between management and the union. It was because of lack of PPEs, and where there were PPEs, they were not in a good standard. And the other issue, which was really of major concern in Limpopo, was the X-ray, the radiography department. I mean, the building was dilapidated as well, you know, where the radiography was being done. There was no privacy. There was no place for patients to change where they could actually have privacy. So they had to create a little corner there for them to be able to change. So it was really a bad turn of events, but also the moratorium had been issued in respect of payment of overtime. Now, there is this huge shortage of staff, and then you don't want to pay overtime in order for the existing staff to fill the gap. So that was a major challenge, but also they are covered, the place that they had demarcated as their covered area, there was no lavatory for male and female. So both male and female were using the same lavatory, and those who were suspected of having COVID from those who were confirmed to have COVID, there was also a problem in respect of that demarcation. They had actually indicated that those who had COVID, I think the male section, they actually had to give them a bowl for them to relieve themselves, which is really a situation which is not desirable.
All right. Quickly, there was one hospital that you guys visited in Pumalanga, I think Temba Hospital.
Yes, we went to Temba in Pumalanga. Temba is actually where we found there was a good relationship between labor and management in Temba. They were in agreement of what the challenges were in Temba. What we found to be heartbreaking in Temba, and because we had also gone to Temba during the Women's Month, I think, and their maternity ward is really in a terrible state. There are no beds, there's no space, there's not even space to just put the babies, you know, it is really in a state which should not be. And also, general space at Temba Hospital, there were also issues of laundry, challenges of laundry at Temba, vacancies. I mean, the vacancy that we actually thought should not even be an issue, they had an issue that even their cleaners could not be filled, their cleaner positions could not be filled, but also the issue of maintenance, the relationship between the Department of Infrastructure and Health in respect of maintenance, the maintenance of their laundry machines and other infrastructure services within the hospital was quite a challenge.
Yeah. All right. So we've seen, all of these in your report, and you have, dubbed your report a factual report, right? Now, what is the next step? At what point do you guys engage with the executive authorities, in terms of, them correcting the situation in the short term, in the medium term, and in the long term. So maybe can you just take us through in terms of, now that you have released this report, what then? Are there engagements that have already taken place, in preparation for whatever remedial actions that you guys are going to be coming up with in your report in the first quarter of next year?
This report that we have released now is actually out of our ordinary course of investigations. Because of the dire situation and the fact that there's no time to wait and say we will actually wait for our formal investigation processes, we have decided to issue a factual report. This is our intervention report, where we are saying these are the factual issues, and from our meeting with the Minister of Health, these issues that are not in dispute. Let us have a plan on what interventions are going to be put in place and within what reasonable timeframes are we going to put these interventions in place. Now, what we've agreed upon with the Minister of Health was that we will then have this report sent to him, which we have already done. He will then coordinate a meeting of the MECs, his MINMEC meeting, where we will discuss this report and agree on timeframes for implementation of the short term, because we are also conscious that there are budgetary challenges within government. So we have to be reasonable in our approach so that we are able to get a buy-in for government to be able to better the most pressing services. So we agreed on those, and we've agreed to categorize in terms of short term, medium term, and long term. So that meeting we are really hoping to have early next year, and if possible, but also the minister was very impressed, and he had said it is also what he had picked up when he came in as the Minister of Health. So we are quite confident that we will have this engagement. But we have also sent this report to the premiers in the provinces and to the MECs. And I'm aware that the Eastern Cape has actually contacted our spokesperson to say that they have not received the particular report. And I had requested staff in the PPSA office to ensure that all the premiers and the MEC's offices actually receive these reports so that they can start the work. Even before we meet to put up these plans, they would have received these reports and they would have started with the interventions. Some of the areas have started with interventions, like Sulengama has started with the interventions, but it is to ensure that they are properly monitored, they are expedited, and so forth. Now, this is the intervention report that we have just released. This doesn't take away our ordinary course of investigations. We've already issued allegations letters to all the provinces in respect of what our inspection has observed. Now, some have responded to the allegations letters. Some provinces like Gauteng, Eastern Cape are ready with their preliminary report, which we call our Section 79 report, where we say, these are the allegations against you. This is the evidence before us, and we are likely to make adverse findings against you. It's an audi alteram partem, where we hear the other side of the story formally, where they present their particular case, and then we finalize the report, make findings, and where appropriate, remedial actions. Now, our remedial actions are binding. Several courts have found that in several cases that our remedial actions are not just there to be observed, but they are there to be implemented unless you go to a court of law to have them set aside or reviewed. But where we are now in most of the areas is at the stage where we are issuing our preliminary report. And this is a project, by the way. Our COVID matters are a project, but health goes beyond COVID. It goes to the actual state of affairs of the healthcare facilities in our country. So it is a report that will live beyond COVID. So we are hoping that by the end of February, we would have issued the final report in respect of the state of the healthcare system in South Africa.
And the remedial actions thereof.
And the remedial actions, yes.
And what if they are ignored? we have heard that you guys release your reports from time to time, but some executive authorities don't really take them seriously for them to be able to do what is necessary. So how can you guys make them bite?
Firstly, as an ombuds, PPSA is an ombuds, and we try by all means to have cooperation before we implement our hard powers. We do have the hard legal powers, but we always say sometimes the hard powers don't give you the required results. Let's just try and find cooperation. What we've done now, firstly, is by our engagement with the Minister of Health, and whom I say is quite cooperative and also very sympathetic to the situation that's happening in South Africa. And as we've seen now with the second wave, he's immediately intervened in the Eastern Cape. But also, for example, the Eastern Cape Premier's office just called our spokesperson to say, we want to see the report. We are hoping really that this is in line of cooperating. But be as it may, what we are doing now with all our remedial action is that we are engaging Parliament. We are engaging Parliament to say that the portfolio committees responsible with the respective departments against which we have remedial actions must exercise the required oversight in ensuring that our remedial actions are being implemented. Now, those are the soft powers that we are utilizing, but we are also engaging with the departments. For example, we have a pending meeting with Foresight, which is the forum of all the DGs within government in respect of the implementation of our remedial actions. We've had a meeting with the DG of Public Service and Administration, as well as the DG in the presidency, who are both responsible for service delivery in the country as well as for monitoring and planning within the country, to ensure that there's cooperation with Public Protector South Africa as envisaged in the Constitution, and there's implementation of our remedial action. Now, when that does not happen, we have the powers to enforce our remedial actions through a court process where there will actually be a court order that this remedial action has been sent out. There is no cooperation, there's no implementation, because we give time frames. Within 30 days, this must happen. Within 60 days, this must happen. Within 90 days, this must happen. So we must be provided with a plan and updates, which some institutions do. Yes, there are those who do not do it. But in respect of this report, I must say the Public Protector and I are highly committed to see that whatever that we come up with is going to be implemented, because it is a dire situation. We need to instill the confidence of the public in the healthcare system in our country. So if the cooperation fails, we will definitely ensure that our remedial actions are being enforced. And the law is very clear. Our remedial actions are binding unless set aside by a court of law.
All right. Now, we are in a country, just a few weeks ago, we were celebrating what is called World Universal Healthcare Day. Basically, a day that the WHO and the United Nations celebrate. I think it's the 6th year now of that, where every country is being encouraged that by 2030, there must be a universal healthcare system. And in the South African context, national health insurance, is going to be that universal healthcare system. Now, with what you have found, and also mindful of the 9-point plan by our National Minister of Health, which targets a number of the areas that you guys have, found gaps in. Do you think the target of 2026 to roll out national health insurance to all, corners of South Africa is going to be on track, considering also, COVID and the financial challenges? Where you're sitting, obviously, you just, looked at 5 provinces, but you got a sense of what's happening. Now, the infrastructure backlogs, staffing shortages, the fact that actually, a lot of colleges for nurses were closed, Lot of institutions. I mean, I was talking to somebody else who talked about the closure of a veterinary unit at Svstem, that used to produce quite a number of, So my question here is, with what you have just seen, and mindful of the 2026, where the country would like to make sure that everybody, irrespective of their their station in society, how rich or how poor they are able to get quality services. Do you think in 6 years' time we will be in a position to ensure that everybody in this country has got access to quality healthcare service as our constitution guarantees?
Doc, in our country, we've got very good laws. We developed the greatest of policies and all of that. And the bottom line of all of that is implementation. And implementation comes with the will, the will of those who are entrusted to implement, to ensure that there is concise implementation thereof. The minister's 9-point plan actually speaks to what we have actually worked on, and that's the conversation we had with him when we had our meeting. And it's as if you were in our meeting, because we also discussed the issue of the NHI, and the PP and I said to him, at this state of affairs, we are actually worried, and we are actually committed to assist you to ensure that come the time when you roll out the NHI, you would have instilled public confidence in the healthcare system, in the public healthcare system. So I think really where there is a will, there is a way. If they stick to the plan, and if with our assistance, with the report that we are going to issue, beginning with this factual report, if we have a clear and concise plan, which we are going to monitor very strictly, I believe that we will be able to be ready, and we will be able to instill public confidence within the system. But most importantly, especially when it comes to NHI, what we had also mentioned is that there's a lot of public funds that are going to be involved. The Department of Health must be decisive in respect of dealing, especially with the corruption that has taken place during COVID. Because if you've got a challenge with managing the budget of COVID, what is then going to happen when NHI is going to be implemented, which is going to be much bigger of a budget? And those are the questions that the public are asking themselves. So if the Department of Health really sticks to the plan, is decisive, I believe that 5 years from now is time enough for them to prepare.
All right. You just touched on the issue of corruption. Are there any cases that have been brought to PPSA around, the alleged widespread corruption in the provinces, where it's a free-for-all, and PPEs, and not only departments of health, but other departments as well, and state agencies? So, I'm just being opportunistic here now. Are there any complaints that have come to your offices for you guys to investigate, issues relating to corruption of the COVID-related, funds?
Yes, there are. We have also reported in our previous press briefings and also to Parliament, which is public, that we are investigating corruption regarding the COVID funds in many provinces.
And are you getting cooperation in the provinces?
Yes, we are getting cooperation. We have powers to subpoena, so where there is no cooperation, we actually do subpoena, and then they are forced to comply.
Lovely, lovely. The same, this celebratory day for universal healthcare, the national minister did mention that, in spite of the fact that many people think that, maybe the plans for NHI should be, revised, basically. But what he said was, actually, this is the best time. Most countries that have put up universal healthcare systems, they have done that when their countries are in a crisis. Like in the UK, their NHS system came at a point where they had just gone out of the, First World War. you know, and there was actually a consultant from the UK who is advising our government as well, who said this is the best time to actually, you know, move on with a bit more speed to actually, you know, have this NHI, you know, being rolled out. I'm one of those people who's still a bit skeptical around the implementation. I'm fully bought. I've fully bought into the idea of universal healthcare, but you know, with all of the kind of things that you showed, quality of leadership, quality of management, you know, leveraging of technology to actually make things a little bit better, you know, staffing solutions and all of that. So, and the fact that the pilots did not really, you know, give us returns on our money, you know, so I've got that skepticism, but at the same time, I'm in support of universal healthcare. So I'm glad that you are actually adding your voice to others who are saying, you know, if there's a will, you know, this thing is possible. So, but I think I need to thank you for giving us an hour and 15 minutes of your time, DPP. The intention of this, you know, conversation was to really share what you guys found with the people of South Africa, and also encourage people, you know, that, you know, you have the powers, and if things don't get corrected, you will be there, you know, standing for them, making sure that the executive authorities deliver on what's expected. Because as a country, we're spending enough money on healthcare, at least about 8.5% of our GDP. You know, we should be getting better outcomes as a country. But the challenge is, how do we use those funds? We have not been using them efficiently as a country to get better outcomes. So we will rely on, you know, Chapter 9 institutions like yours to make sure that the responsible departments deliver on their mandate. So I want to thank you for giving us your time, and looking forward, you know, to making sure that we invite you when you guys come up with that report that will have some remedial actions sometime end of February or beginning of March. So thank you very much. And I also want to thank all our viewers who were watching this interview. I hope you got a better sense of what came out of the Blitz or Blitz audit that was done by PPSA in all of these provinces, 5 out of the 9 provinces. And you now have a better understanding of what role they can play in ensuring that ordinary South Africans get, you know, the kind of services that they deserve. So I want to thank you, DPP, and thank everybody who joined in. May you have a joyous but safe Christmas with your family, and come back in 2021, you know, COVID-free.
Thank you so much, Doc. Thank you so much. And I just want to emphasize to the public that really, as Public Protector South Africa, we are committed to ensuring that there's good governance, but most importantly, that there is ethical leadership. Good governance on its own will not be able to resolve the challenges that we are having. We are mostly human resource dependent, meaning that ethics needs to be the driver of what we are intending to achieve. And thank you very much to your viewers, and a blessed and a safe festive season to everyone.
Thank you very much.